Welcome back to our discussion with Dr. Randall Ellis. Dr. Ellis, thank you for your insights and the work with Seed Global in Uganda in building the emergency medicine infrastructure. You mentioned that with every project, every locale, of course, and every community comes some unique insights and lessons learned. Are there any common challenges that you have encountered in trying to bring emergency medicine to under-resourced areas globally?
I think one of the most important things is to have the support of the Ministry of Health. If you don't have the support of the Ministry of Health, it is going to be extremely difficult to get anything done. And the Ministry of Health has certainly been very supportive, and it's one of the initial parts of getting Seed Global Health involved. As I said, Seed does not go into a place and tell them what they need. They will, if they are asked to partner with the Ministry of Health and a partner university, they are glad to work that out. Um, the the other thing is, and it goes along with having the support of the Ministry of Health, it does no good training, whether it's physicians or emergency nurses or whoever you're training, in anything that Seed Global Health does, midwives, pediatricians, various things. If after their training they can't get a job, the Ministry of Health needs to continue to create job opportunities for this within their workforce and paid positions, because one of several things will happen if there aren't paid positions available. They may go to a different country. Uh, they may end up just doing something else besides that. Or, earlier on, they just decide it's not worth it to go through the training, say becoming an emergency physician, or when it happens, an emergency nurse. It's a waste of time to go through the training if they, first off, aren't going to have a job available. And second, there's not going to be some economic advantage to doing that. They're going to take 3 years of their life. They should not only have a job available, but there's going to have to be some pay increase along the way, or they'll just stay in the position they're at. So there has to be some incentives for people to want to do this and continue to want to work in the area and work in Uganda. The training programs in Uganda are actually training a number of people from other countries in East Africa also. We have residents from Kenya. Kenya does not recognize emergency medicine as a specialty at this point. It's actually a more populated country than Uganda, and bigger country, more spread out with more rural areas. Hopefully that will change soon. But currently, we do have some Kenyan residents. We've had a couple of residents from Somalia. I believe we have a current Rwandan resident. And although Rwanda does have an emergency medicine as a specialty, and so does Tanzania, but particularly Somalia and Kenya, we have trained people that will then. So again, it's another knockoff effect. These trainees will probably leave Uganda, but that's okay as we see it, because they're going to another country that needs emergency care. And hopefully they can be in the early development and actually advocacy of starting emergency care development in their country, particularly and hopefully Kenya soon.
Yeah, that makes total sense. You mentioned a lot the importance of the Ministry of Health. I mean, of course, you can't go into someone's country and tell them what to do. You want to work with them to help them develop what they want to do. But with that, Are there types of healthcare systems that make it easier for you to develop this sort of infrastructure around emergency care? And are there other types of healthcare systems that have more challenges?
Certainly, in some ways, a government and Ministry of Health as an arm of that government um, that has more control over the healthcare system. I'm not making a judgment on whether that's good or bad, but it does make it easier to work with the Ministry of Health and get things done if they actually have control over the levers of what you're interested in. In other words, if you have a decentralized uh, healthcare system, it makes it a little more difficult. It certainly makes it more difficult to get anything done on a nationwide scale. You can get things done locally, possibly, but to get things done on a bigger scale, we were talking about before the break, scaling things up. It makes it easier to scale things up if you have a Ministry of Health that is actively involved and interested and also has control of some of the levers that you would need to do that. On the other hand, if you have a very controlling and active Ministry of Health, but they're not interested in development, they can really squash your efforts. You know, one thing that talking more continent wide in Africa that has led to the development of emergency medicine as a specialty in a lot of these countries is the continuing increase in trauma deaths across Africa. It's becoming a major source of mortality and morbidity across Africa, particularly with the increase in the number of roads, multi-purpose roads with people walking and on bicycles and motorcycles and more cars uh, on these roads and highways. Um, Trauma deaths across the continent have soared dramatically. And one of the responses in many of these countries has been to improve the emergency medicine development from pre-hospital care to hospital care to more specialized trauma care.
Thank you. That was amazing. So I think what maybe a lot of people don't know, right, in the United States is the United States has a decentralized healthcare system. So this is the perspective that we are looking from. But many of the countries in Africa are looking at universal healthcare or currently have universal healthcare systems. And so when you speak of working with the Ministry of Health in those systems, you have greater ability to coordinate across the healthcare system than you would in a private or decentralized healthcare system. Am I getting that correct?
You are getting that correct. That's certainly true. And in a place like Uganda, I'll talk about Uganda in particular. There is, on paper, universal health care. There are certainly public health hospitals and facilities that everybody can go to, and they get a baseline level of care. And anything over that, they do have to pay for. And sometimes, particularly when I was working there, I wished that baseline was higher. We needed to do more things than would be covered by this, and hopefully that will change over time. There's also, in addition to that, private hospitals in Uganda. So people that have more money or happen to have some type of healthcare insurance could possibly go to these private hospitals. And what happens in Uganda is very similar to what can happen in a lot of places, including the US, which is private hospitals can sometimes afford to pay employees a little bit more. So they may be able to get some of the 17 physicians that are trained in emergency care to their private hospital, which is depriving public hospitals that are serving uh, more rural and poorer people um, the healthcare workers they need. When you have a healthcare worker shortage, there are certain places that feel the effects of that more than others. Whether you're in Uganda or whether you're in the U.S., the U.S. has a serious healthcare worker shortage in rural areas, in particular. That's a real problem. It's a real problem in Uganda also.
That is true. I was definitely going to mention that that is a problem also here in the United States. I mean, we talk about it as the brain drain, but you people here spend a lot of time and money training to become specialists or physicians or nurses. And then it's very difficult to keep those folks in a rural community where they will have less economic opportunities. Perhaps their families will have less economic and educational opportunities. So there's always this tension with how to train people and still keep them involved. It, perhaps not even physically located, but involved in the healthcare of the communities that they come from, because they do have an emotional and a social attachment to those communities. Have you seen any innovative ways, or are you using any innovative ways to help that happen?
I can't. I'm. We've been talking about Uganda a lot, and I'm thinking in Uganda, it's certainly such a big problem, and at least in emergency care development, still in the very early stages of this. I think right off the start, a lot of the healthcare workers, understandably, and they are actually needed to go to some of the bigger referral hospitals. They really do. At this point in time in the development in Uganda, the rural hospitals need a place at least to send their very sick patients. We need to do more training on how to stabilize these patients and also transfer these patients in a safe manner, but they need a place to send them where there are people that are trained and qualified to resuscitate them and take care of their needs. In any development of a specialty like this, it's going to change over time, as it has in the US. As time progresses and there's hopefully more healthcare workers in these rural referral hospitals, we can get better emergency care and better trained emergency personnel out to the outlying hospitals and actually rural hospitals themselves. That's going to be a long-term issue and a long-term project. I think at this stage in Uganda, it's basically having the Ministry of Health create the jobs that are needed to incentivize medical school graduates to do training in emergency medicine, and also for the emergency medicine residency graduates to stay in the country and want to work in Uganda. They need jobs that will incentivize them, generally through pay and opportunity to advance, to stay at these jobs and stay in Uganda.
One of the things that are sort of our foundational principles in Healthcare Alliance is that we believe that we can use telehealth to support rural areas with emergency physicians' guidance, and to use emergency physicians to help whoever is working at a rural community be able to better stabilize and or diagnose patients. Do you think there is a role for telehealth in emergency medicine in rural, under resourced communities globally?
The simple answer is yes. The more complex analysis of that, I would have a couple of things I would say. Telehealth, kind of in quotation marks, telehealth has a number of different ways and modalities it's used. People, even if there's not official channels of telehealth, they find their own ways. The healthcare workers find their ways of doing telehealth. And what I mean by that is I'm on many WhatsApp groups with Ugandan healthcare workers, and they're frequently sending out x-rays and CT scans and EKGs and saying, what do you think of this? And they're trying to get opinions of other people and things like that. those are definitely not official channels of telehealth. And that's not exactly what you're talking about. I understand, but all I'm saying is people are hungry for telehealth and they will create their own form of telehealth if they aren't given an organized way of doing it. Having said that, yes, telehealth in a more organized fashion would be very helpful, particularly since we're talking about a specialty that doesn't have, and for the foreseeable future is going to be way underserved by the number of actual specialists in the area. To be able to reach out from some of these places to a specialist and ask questions and do it in an organized, formal manner and get advice on resuscitation and stabilization and transfer of these patients. Yes, it would be very helpful. One of the challenges, and it's not only a challenge in Uganda, it's a challenge anywhere that you're going to run into, is connectivity, internet connectivity, and or cell phone connectivity to some of the rural areas. Some of the places that need it the most are probably going to be the most challenging to get to. But having said that, even in the time since 2018, once I started working in Uganda, the connectivity in Uganda has improved dramatically and just continues to improve. And I only foresee it continuing to improve. So, yes, there is a need. People are asking for a need. They're showing a need by creating their own form of telehealth. So, having an organized platform for it would be fantastic.
What are the greatest needs? So we have an audience that's going to be listening to us. Some of them will be trainees, like the folks you're training in Uganda. Some of them will be physicians. Some of them will not be in medicine at all. But they will all be people that are interested in this conversation in global health and in how can we make healthcare more equitable for everyone. What would you say are your top three next things you would ask, whether it be policymakers or leaders or just trainees, to focus on to make a difference for global health?
Across the board, kind of mentioned it early in global health. And if you work in global health, you will see the good, bad, and the ugly. I had seen it before I went to Uganda. I saw it in Uganda. Um, I just think that if people are going to support organizations doing global health, do a little research and make sure what they're actually doing is sustainable. And sustainable, the definition of sustainable to me is, are they increasing the capacity of the people in the country where they're working, whether it's knowledge capacity, healthcare workforce capacity, somehow they're increasing the capacity. If they're just dropping in and providing healthcare and then dropping out, the next question is, if the organization, for example, if Seed Global Health tomorrow just went kaput and was no longer there, would there be any benefits left behind by what Seed Global Health's work has been in Uganda? And the answer is a clear yes. We've trained a number of people. I feel confident that if for some reason we had to leave tomorrow, we could. I mean, COVID was a good example. We did leave for a while. There was a country team there, and we were still supporting the programs and things like that. Our educators left the country, most of our educators, and everything continued on. The people we had trained took care of the patients that were there, and we got to see a lot of the results of what we've been doing. So, whether you are in healthcare and end up choosing to work in global health long term, or even short term, or you're not in healthcare and want to support organizations, please do your homework, because I think some organizations, although they have good intentions, if they're not improving the capacity of the people in the country, they are sometimes doing more harm than good.
And we've heard that from our previous guests as well. The importance of not just coming in as a short term visitor, which can be disruptive actually to the local healthcare system and definitely disruptive to the trust of the community.
Agree, absolutely. Oh, yes. And you're actually undermining the healthcare system as opposed to what, and we're not the only organization doing that. There's plenty of organizations doing very good work and sustainable work, but it really should be that they are working with partners in the country. Seeds working with the Ministry of Health and the universities, but they need to be directly working with the partners. And also, they're not going in with their own agenda um, that we as outsiders have decided this is what you need. Um, that never goes well and is not helpful at all.
So, how do you get involved in these countries? How did they come to you to ask for what they need?
My global health journey probably started more than 15 years ago. And basically, it's been a lot of networking. You get to meet people like you at conferences and or in a different country, and you hear about other organizations. You see what other organizations are doing. Some organizations you see and you're thinking, I will never work for them because I don't like seeing what they're doing on the ground. They're not really building sustainability. They're kind of coming in with their own agenda and patting themselves on the back and saying, aren't we doing a great job? And my answer is no, you are not. But it's been a lot of networking and various things, which then that journey led me to Seed Global Health. And like I said, I was very attracted to their work because it really is sustainable. And I'm only going to do global health work that is sustainable. I have no time or energy or passion to do work that is not sustainable because everybody wants what they're doing to matter and not just matter today, but actually creating something that's better for the future.
Okay. How can, if someone wants to contact you, how can they contact you?
If you go to the Seed Global Health website, I am on the Seed Global Health website, and they can certainly contact me that way. Uh, I also have a Twitter account, which I guess is now X. It's Global Med for All. I had Global Med for All. And I will just give out my email address, rellis at seedglobalhealth.org. They can certainly feel free to email me. I'm always very interested and passionate to discuss things with people that are interested and passionate about global health issues.
Randall, is there anything I might not have asked that you'd want to share?
You know, and we could probably just talk on and on about global health and what's going on. I think we covered most of the major things. One thing I want to point out was we met at the conference in Albuquerque, and one of the talks I was giving was talking about the response to Ebola that occurred in October 2022 in Uganda. And I think the response was indicative of why it's so important to build a baseline and have healthcare workers that are trained and know what they're doing. So in October 2022, people may remember there was an outbreak in Uganda of Ebola. It was the largest Ebola outbreak since the West Africa Ebola outbreak in 2014. Fortunately, it did not become that big, but it did. There were, as I remember, over 500 cases. And we used the ECHO platform, which had been developed for emergency care training, but we used a platform that was already set up for that to get knowledge out to the healthcare workers around the country about Ebola. the biggest thing was what to look for. How do these patients, what kind of symptoms do they have? When should you think about it? When should you isolate them and do testing and various things like that? It went very well. We did a specific Ebola training, 2 hours a day for 5 straight days. It was wildly popular. There were over 1,000 logins. Many of the logins were multiple people on a login because they were logins at a hospital, and there may be 5 to 10 people on each login. Some of them, so it's really unclear how many people were involved. There was a lot of interest for it, and things did get turned around. Fortunately, there is no longer currently an Ebola outbreak. By January of that year, the Ebola outbreak was declared over. I'm not saying it was all because of what we did with that. It was multiple reasons for that, but people had an interest in the outbreak. They had an interest in the response to it because of a lot of the emergency care training they'd been doing. Um, they were able to resuscitate the people that were sick, and we also had the platform to be used to spread knowledge about the Ebola outbreak. So it was actually the first time that the Project Echo platform had been used in an epidemic like that to spread knowledge around the country. So that was a very useful thing, and it was partly due to the interest in emergency care from the Ministry of Health, and also some of the support that Seed Global Health was doing, both for the ECHO project and a lot of the training and spreading of knowledge around the country. So we were very proud of that and that work. And, I took a small part in this, but believe me, this was, again, and this is the way it should be. This was not done by Seed Global Health. This was done by Ugandans. Ugandans did all this. They were the majority of the experts on the panel and spreading the knowledge. They were the people that were listening, and the trainees on these ECHO projects. And they did a fantastic job of getting the information out and getting the Ebola outbreak under control. So kudos to the Ugandans. We were just glad to be a small part of that and supporting that.
And we'll give a little shout out to Project Echo, which brought us together. Project Echo is now a global medical education platform, but it started with Dr. Sanjeev Arora, a gastroenterologist who was working in a very rural state where he was struck by how patients could not get access to, for instance, his gastrointestinal specialty knowledge and how to take care of life-threatening liver diseases in areas that were hours away from the hospital where those patients would not be able to come in and get medical care. So he started doing this educational series to local primary care physicians. And that has developed into a global educational platform that is all over the world. And like Ebola, it's also been used during the COVID pandemic and been used in conflict zones to help with educational. So I don't think he meant to start out with a telehealth, not just innovation, but a major telehealth platform. But that is essentially what it has grown into, and it's been very high impact for a lot of people. So a little shout out to Project Echo.
Yeah, absolutely. Project Echo is doing some very good sustainable work. And, this was a good example of collaboration between two NGOs, Seed Global Health, Project Echo, and then the Ministry of Health have been the ones that have really come together and created this Echo platform that's being used to spread emergency care knowledge I think that's one problem I certainly see in global health. I think there's too many silos of individual organizations doing their thing, and they're just doing their thing. And even if they're collaborating with people on the ground and doing sustainable work, they're not collaborating with other organizations that maybe either are doing similar type work or not doing similar type work, such as Project Echo, but doing work that would be a benefit for the work you are doing. So I think there needs to be a lot more collaboration in global health. There's not enough of it.
And I certainly did not prompt you to say that. Part of the reason we're building this community and having this conversation, we will have people doing this work from all over the globe come and tell us what they're doing and listen to others that are doing work. And I hope with that, we'll find the connections and the community and become a global community of equity advocates and innovators, not just advocates, but innovators doing things and coming together. Because this isn't the kind of work where anyone can win. There's no winners or losers. This isn't a corporate battle to the finish line. The only way we're going to make a real difference here is for all of us to come together and work on the same outcome. Randall, thank you so much. It's been a pleasure.
Thank you, Kim. It has been a real pleasure, and I'm always glad to share the work being done in Uganda. So proud of what's happening there. Thank you.
Well, if you have more projects and new developments, we will be glad to have you come back and talk more about the work you're doing. Please know that you have a place here to come and talk with us about what's happening and help others learn about what's happening. If you enjoyed our episode today, please share it with a friend who you think would also enjoy this topic and conversation. Please also leave us a review, as we'd like to hear your ideas and feedback. If you'd like to be a guest on our podcast, email us at infoinfo@haew.org. And if you'd like to learn more, join us, partner, or donate, please go to https://haew.org. Randall, thank you so much.